Celiac disease has many synonyms and defined as chronic inflammatory disorder of the small intestine characterized by malabsorption after ingestion of gluten in genetically susceptible people. By module age of distribution and more common in females.
Etiology and pathogenesis. Celiac disease results from a combination of immunological responses to an environmental factor, which is exposure to dietary gluten, and genetic factors as it occurs in genetically susceptible hosts related to human leukocyte antigen HLA-DQ2 and HLA-DQ8. Diagnosis. The diagnostic scheme consists of the following: clinical history and symptomatology, serologic testing, histologic findings in proximal small intestine biopsy, genetic studies, clinical and serologic, optionally histologic response to gluten-free diet.
Clinical presentation varies from mild to severe symptoms, which is not associated with the severity of the mucosal lesion but mainly related to the length of affected bowel. Strict adherence to gluten-free diet is very important. Laboratory tests. Tissue transglutaminase is 90% specific and sensitive, and the serologic test of choice, serologic positivity, correlate with the degree of mucosal damage. Patients with gluten-free diet have normal antibody titers.
Despite the development of new serologic tests and genetic analysis, enteric biopsy continues to be the gold standard for the diagnosis of celiac disease, particularly in less severely affected patients with mild mucosal abnormality.
Macroscopic features. Scalloping and loss of folds is not very specific. Involvement is patchy. Biopsies should be taken of both distal duodenum and duodenal bulb. Biopsy orientation is a crucial event. This slide demonstrates normal enteric mucosa features. Microscopic features. Increased number of intraepithelial lymphocytes, variable villus abnormalities, crypt hyperplasia, increased lamina propria lymphocytes and plasma cells, accumulation of red globules in surface epithelium.
The most commonly used grading system for celiac disease in enteric biopsies is modified Marsh criteria. Marsh 0 is normal biopsy. Marsh 1 showed normal architecture with increased intraepithelial lymphocytes only. Marsh 2 showed crypt hyperplasia with increased intraepithelial lymphocytes. Marsh 3A showed mild villus blunting with increased intraepithelial lymphocytes. Marsh 3B showed marked villus blunting with increased intraepithelial lymphocytes. Marsh 3C showed totally flat biopsy with increased intraepithelial lymphocytes. It is important to note that the Marsh criteria are intended for use in patients with established celiac disease to stage their condition. Villus atrophy is not pathognomonic of celiac disease, while characteristic histologic findings are not diagnostic. Only response to the gluten-free diet is diagnostic. Microscopic features of Marsh stage. Marsh 0, normal biopsy. Marsh 1, only increase of intraepithelial lymphocytes. Marsh 2, crypt hyperplasia with increase of intraepithelial lymphocytes. Marsh 3A, mild villus atrophy with increase of intraepithelial lymphocytes. Marsh 3B, marked villus atrophy with increase of intraepithelial lymphocytes. Marsh 3C, flat biopsy with increase of intraepithelial lymphocytes.
Differential diagnosis: disorders with architecture abnormalities and/or intraepithelial lymphocytosis.
Tropical sprue involves terminal ileum, lamina propria, eosinophils, only mild to moderate villus blunting. Peptic duodenitis, neutrophils rather than intraepithelial lymphocytes. Autoimmune enteropathy, intraepithelial lymphocytes infiltrating the crypt epithelium rather than surface epithelium. Non-steroidal anti-inflammatory drugs, intraepithelial lymphocytes in a non-tip predominant pattern, lamina propria, neutrophilic infiltration. Bacterial overgrowth, neutrophils more than lymphocytes. Complication: refractory celiac disease, enteropathy-associated T-cell lymphoma, collagenous sprue, adenocarcinoma of the small intestine. Treatment: lifelong gluten-free diet, and a number of new treatment approaches are being investigated. Prognosis: clinical improvement occurs within 48 hours of gluten-free diet, for remission in weeks to months. Some patients may become refractory to gluten-free diet many years later, refractory celiac disease, while some sign that lymphoma may be developing. Take-home messages: short-term blue is not always sprue, which means not all short villi and intraepithelial lymphocytosis is celiac sprue.